to talk today about BPH, which is a benign growth of the prostate. So, well, one of the most common questions that I get sometimes is what is the main function of the prostate? And basically, what the prostate does is produce a fluid that allows the sperm to flow during the ejaculation. So, usually, the prostate is very important when you are creating your family. But once you accomplish that, basically doesn't give you any function other than with time, as you get older, the prostate keep growing, and sometimes can give you problem empty your bladder, because as you can see, the prostate is just sitting in front of the bladder. So the bigger the prostate you get, the more difficult for the bladder to empty. In general, the size of the prostate is it shouldn't be more than 20 grams, or 20 cc's in volume. So it's very small. So we're going to be talking about BPH, as I said before. So BPH is a benign. So benign means it's not cancer. Is a growth. Hyperplasia means a growth of the prostate. So it's a benign growth of the prostate. That's what BPH means. As I said before, the normal volume of the prostate is about 20 cc's, 15 to 20 cc's, and that will translate in about 1.5 inch. And certainly BPH, which is a benign growth of the prostate, is related to what we call lower urinary tract symptoms. And those symptoms can be related with frequency, urgency, waking up at night, and that can be an indication that your prostate is enlarged. It is very important to highlight that BPH is not prostate cancer, okay? And BPH does not cause prostate cancer. And sometimes the prostate cancer and BPH symptoms can be similar, frequency, urgency, blood in the urine, waking up at night. And that is sometimes what may confuse the patient, but BPH is not prostate cancer. PSA is one of these blood samples that we do for prostate cancer, but as well, we can use it for get an indirect measurement of how big could be the prostate. So if I get the PSA and I get the prostate volume, that will give me an idea of something that is called PSA density. And that is a number that the higher you get, the more concern I get for prostate cancer. The lower you get, the more I think the patient has BPH. So the PSA allows us as well to make a determination if we need to be concerned for prostate cancer or not, or we need to only be concerned about enlarged prostate. As I mentioned before, the prostate is sitting on the left side. You see the normal size of the prostate. So when the bladder is full, start empty, and then the urine is able to go through the urethra that is surrounded by the prostate without any problem. So, but now if you have that prostate growing, and that will start obstructing the urethra, and therefore giving more difficult time to the bladder to empty. And therefore those patients may not, when they go to the bathroom, they may not empty completely. They start leaving behind is what we call post-void residual. And by never empty your bladder, you start having the frequency, you start having that urgency, and therefore could be an indication that your prostate is enlarged. So as we say, and we're going to keep repeating these over and over throughout the presentation, what are the symptoms of frequent urination? So that can happen during the day, or it can happen at night. You have the sudden urge to urinate. You tell me, Dr. Davila, and as soon as I get the urge, I better run to the bathroom because I'm not able to hold it as good as before. That's an indication that your bladder is being affected as well by this enlarged prostate. Hey, Dr. Davila, I'm having problem. My flow is not as good as before. It's weak. I'm dribbling at the end. Sometimes I'm thinking that I'm done and I still have a little more, that I can empty. So those are some indication that you start having problem. Sometimes as well, and this is when sometimes can be confused with an infection of the urine. The patient may tell you, I have a burning sensation when I empty, and may not be related to an infection, could be only be related to an enlarged prostate. And of course, is what we always want to prevent this to happen, which is the inability to urinate. So sometimes the patient, wake up in the morning and say, I'm not able to go on. The patient, after 6 hours, is in a tremendous pain, of course, and they ended up going to the ER, or they can come to the urology office and we can help them. But we usually, as a urologist, we want to prevent this to happen. Once this happen, is telling me that the bladder may be affected already by the enlarged prostate. So as you see, 95% of the patients that present with these symptoms, these symptoms are affecting their quality of life. So I tell you, Dr. Davila, when I'm playing golf, I have to go behind the tree every other hole. Is becoming a problem for me to play tennis. Is a problem becoming a problem for me to play, golf. Is affecting my fishing. So the daily activities that patient enjoy is being affected because they're looking for a bathroom all day long. As well, it is important to know that an enlarged prostate can present as well with problem with ED, erectile dysfunction. Why? Because ED as well present as we get older. BPH present when we get older. So it's the same demographic of patient. And sometimes there is a medication that we use for the ED that we can give it in every day, daily, and it can help both BPH symptoms and as well sometimes the ED can improve with this approach. So, so certainly, as you see, these symptoms can affect their quality of life and their social life. So how can we get BPH? Well, this is related to aging. I used to have black hair, now I have white hair. Why is that? Getting older. So as you get old, the same thing happened with your prostate. Your prostate get bigger, and that is related to age. About 50% of men by 60 years old, they will have an enlarged prostate, and about 90% of patients by 85 will have an enlarged prostate. As you see, it's not anymore if I'm gonna have an enlarged prostate, is when it's gonna happen, and do I gonna be presenting symptoms or not. About 14 million men in the United States present with frequency, urgency, nocturia, meaning waking up at night. And these, as well as, our society, about 33% of our society is obese. So as well has been related to obesity, and increased BMI has been related to BPH. How can we diagnose BPH, an enlarged prostate? Well, we check the digital rectal exam, which checking your prostate. And when you come to a urologist, that will give us an idea how big is your prostate. But as I always say, the finger is only touching one face of the prostate. Sometimes, really give me an idea how big is the prostate is by doing an ultrasound of the prostate. Okay. And that can give me a volume. So every time that I see a patient in my office, I order an ultrasound of the prostate. So in that way, I can get a real prostate volume. In that way, I can tell my patient with that number, what's going to be the prognosis. Can we handle this with medications or not? As well, there is a test that we do, is called, pressure flow, that you come with your bladder full, and then we ask you to empty in a small container. We ask you, hey, Mr. Smith, are you done? Yeah, I'm done. And then we'll do an ultrasound to see if you are emptying your bladder or not, if you're leaving behind. That will allow me to tell you how much you're leaving behind. It's not the same when you leave 10% behind as when you are leaving 50 or 60%. When the patient is leaving 50 or 60% behind, is telling me that that bladder maybe has been affected already by the prostate. And remember, we as a urologist, we want to prevent that to happen. Once the prostate is decompensating the bladder, it's very difficult sometimes to get the bladder to start working again. So we really need to avoid that to happen. Of course, when you come to our office, we have some questions that we ask you, and that will give you a number. The higher the number, the worse symptoms you have. The lower the number, the less or more mild symptoms you have. So it gives us an idea how severe are these frequency, urgency, waking up at night. What are the options? So as anything that we do in medicine, we go from the less invasive to the more invasive. And as you see on the left side, you see the less invasive approach, and the American Urology Association recommend us to do fluid and diet changes. What that means is I ask my patients, so if they say, hey, Dr. Davila, I'm waking up 7 times at night. Okay, so what time do you go to dinner? Well, I go to dinner at 7. And what do you drink? Well, I like to drink red wine. I say, well, I have bad news for you, Mr. Smith. So that red wine at night, maybe you're going to have to stop it. Okay, because of course, if I take alcohol before I go to sleep, that's going to affect my the urine production. Is going to be waking up more frequently because the bladder is going to be distended. So sometime by asking your patients what time they go to sleep, what do they drink, sometimes, as high as 30% of the time, you can fix the problem without doing anything but changing your diet and what you do. As well, there are, sometimes I ask my patients, to trying to go to the bathroom before they feel the urge to urinate. So, hey, as soon as I feel the urge, I better run. So when that happened, well, it happened after 4 hours. So I say, well, we're not 20 years old anymore. So why don't we try to go to the bathroom every 2 hours? Of course, that can be done during the day, but at night is more difficult. So if you come back, and you say, Dr. Davila, I did all the recommendations that you told me, and, I stopped the wine, I stopped drinking at 6 p.m., any fluid, and I'm still waking up at night, I still have a lot of frequency, then we move to the next step. The next step will be what we call the first line therapy. And on that, we usually start with the medications. There are many medications that we have been using for many years, and we talk about them later on in detail. We have the water vapor, which is the Rezum. We have a permanent implant, which we call the Urolive. And then we have the next step. If you are not improving on the first line therapy, the next step will be the surgical procedures, which are the laser. And on the laser, and this is a question that I always get. So there are many energies: the green light laser, the holmium laser, and the thulium laser. And then there is the TURP, which is the old-fashioned way that we used to treat these enlarged prostate many years ago. I mean, nowadays we do more laser type of surgery. And of course, there is always a possibility to do what we call a simple prostatectomy. But nowadays you can do enucleations, and these can be as good as the simple prostatectomy without having to do a prostatectomy. Again, so there is not any evidence that saw palmetto can be effective and efficient as any other medications that we give for prostate, for an enlarged prostate. So I always tell my patient, be careful, because these over-the-counter medication can be expensive and may not be as effective as patients think. So starting from the less invasive is, of course, doing nothing, is what we call watchful waiting. So say, hey, you do have an enlarged prostate, but the patient is not presenting any symptoms. So for those patients, I don't want to do anything. So sometimes I have patients that they have a prostate volume of 60, 70, 80s. And as I told you before, the normal size of the prostate should be 20. But if I ask them, hey, are you waking up at night? Are you going frequently? No, Dr. Davila, I don't have any problems. So why do I need to give any medication if the patient is not having any symptoms? So if the patient empty the bladder, they don't have a post-void residual, they don't have any problem with the kidney, I will prefer to do nothing. So if the patient start having symptoms, okay, they're not emptying the bladder well. So I usually go for an alpha blocker. And one of the alpha blockers that we have been working for many, many years, the Flomax or tamsulosin, which is the generic, and very well tolerated. Here we have some of the side effects, as you know, dizziness. Dizziness is one of them, and that can happen about 10% of the time. And as well, you know, that can decrease your blood pressure. If you belong to that 10% of patients that are not able to tolerate these alpha blockers, sometimes we go to another type of alpha blocker, a little more selective, like Rapaflow, and see if you are not having any reaction, but sometimes you have reaction to both. But the main idea of this alpha blocker is to open up the urethra that is going through the prostate, so you have a bigger channel and hopefully you are able to empty more efficiently. However, up to 60% of patients, 60 to 70% of patients may stop taking this medication within a year because may not be improving the symptoms. So there are another group of medications is what we call 5-alpha reductase inhibitors. These are, you know, finasteride or Proscar and Avodart. And then these medications are designed to decrease, actually they decrease the size of the prostate, okay? But only affect the size of the prostate by 20, 25%. So if you have a prostate that is 100 cc, it will make a prostate that is about 75 cc. So it's still a large prostate. And this is accomplished in about 4 months. So in order to see the benefit for this type of medication, you have to take the medication for 4 months. And they have some side effect that a lot of my patients, especially the patients that are, you know, 50, 55, 60, they don't like those side effects. What are they? A side effect, ED. They have a decreased libido, sexual drive. They may have problem with ejaculation. Something that is very important to highlight as well about these medications and the alpha blockers, you know, like the Flomax, is they will induce retrograde ejaculation. So meaning that you're going to have an orgasm, but you will not have an ejaculation. Okay. So, and that's as well some of the things that patients complain about it. So as you see, medications are less invasive, but medication have some side effects that need to be discussed with our patient, and our patient, they need to know what are the side effects and the benefit before they commit to proceed with this approach. Then in the first line treatment, as I mentioned before, we have the water vapor, the Rezum, and basically what it does is just to inject water vapor. By injecting this water vapor, it induces what we call apoptosis, which is meaning the cells start dying when you get connected with this, you know, water vapor, and that creates space in the prostatic urethra. By creating that space, you open up the channel, and by opening the channel up, then you have a better flow and a better pressure. And it's a procedure that we do in the office. It doesn't require general anesthesia. It takes about 2 minutes, and it's not painful. You know, from 1 to 10, I ask my patients, you know, if 10 is the worst pain of your life, what is this you know, pain related with this procedure? And they usually give me a 2 or 3. So it's not painless, but it's not painful. There is, as anything that we do in surgery, there are some side effects related to this. And of course, you can have an infection in the urine. How frequently that happens? About 2% of the time. You can have blood with the urine when you start urinating after the procedure. You know, after we do the procedure, I like to leave a catheter in your bladder for 3 to 5 days, okay, to prevent the bleeding. So sometimes patients may complain about the catheter in the bladder. And usually it take about, you know, 4 to 6 weeks to start seeing that, you know, 100% improvement, and the data up to 5 years is quite good. So the about 96% of patients were not retreated within the first 5 years because the symptoms were improved by doing this approach. So here I'm going to put a brief video of how we do the Rezum or the water vapor.
Rezum Water Vapor Therapy is a non-surgical treatment for BPH. Rezum uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Rezum is a potential alternative to drug therapy, permanent implants, and surgery.
So as you see, is as I mentioned before, is under local anesthesia done in the office with a 97, 95% satisfaction by the patient. And here is a brief experience of one of the patients that got the Rezum.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first heard of Rezum when I was researching enlarged prostate and the procedures to repair it, to fix it. And Rezum was one of them. The more I researched Rezum, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Rezum procedure was very good. After the procedure, I was a little worn, a little tired, and the next day I felt fairly good and was able to get up and get around.
Since Joe's Rezum procedure, we're able to spend much more quality time together, fewer interruptions, and we're just happier as a couple. The Rezum treatment has made a very big difference in our life.
And then as part of the first line treatment as well, there are other options, the UroLift with our implants that you put inside the prostate. And by putting this implant, that open up the prostate, and the channel that go through the prostate get bigger. And therefore, as well, the main idea is to improve the flow, the stream, and by doing that, decrease the frequency and the urgency that you have to empty your bladder. And equally effective, the problem is usually about 13 to 15% of the time, these patients need to be retreated because these implants will fail, but as well, can be related to some side effect, which is urinary tract infection, blood in the urine. We do it as well in the office under local anesthesia, take about maybe 5 to 10 minutes. And as well, I like to place a Foley catheter after we put the implants to prevent the bleeding related to sometime placing the implant, and I keep that for 3 days. Then we have the laser treatment. So as I mentioned before, not only the green light, but the green light, the holmium laser, thulium, any energy, basically what you're trying to accomplish is just to open up that channel that is going through the prostate. And the laser is extremely effective with a very high success rate, but these need to be done in the hospital and need to be done under general anesthesia. And then there are different techniques. I don't want to get too complicated on these, but there is a laser ablation, laser enucleation. I like to use the laser enucleation because it's more effective in removing more tissue faster, so I can take care of bigger prostates. But certainly, you will not have an ejaculation after this type of surgery. So if you are one of those patients that are concerned about keeping your ejaculation, so certainly I think the best approach would be either the water vapor, the Rezum, or the UroLift, because once you get into the laser treatment, you will not have an ejaculation. But again, these will not affect your orgasms, and these most of the time will not affect your erectile function. Okay. So here is a video about the laser treatment that I think is important to see. So you see the difference. see that we are advancing the scope with the laser, and then with the laser you start ablating the prostate, and you try to open that channel that goes through the prostate, so that way you have a better flow, better stream, and the frequency and the urgency go away, waking up at night improve. But these type of treatment need to be done under general anesthesia. So, and then the TURP, which is the old-fashioned to take care of prostate, when you know, which is opening and cutting pieces of the prostate, and to basically open the channel, the urethra, and in that way, so you hopefully improve the symptoms of the patients. But this is a little more invasive. The probability of bleeding with a TURP can be as high as 5 to 10%. Sometimes patient need to be transfused. Sometimes patient need to be admitted to the hospital. So it's a little more invasive than the other procedures. And of course, the prostatectomy, which is removing the prostate, but in this case, we call it simple prostatectomy because it's not related to removing the prostate when you have prostate cancer. And we call that radical prostatectomy. So for this case, it's just taking off the benign growth that is blocking, and that can be done with a Da Vinci, robotically assisted, or can be done open. So certainly, as you see, the way to treat BPH can go from doing nothing to first-line treatment. In the first-line treatment, you have the medication, you have the Rezum, you have Urolive, and then on the surgical procedures, you have all the energies, the lasers, the TURP, and the prostatectomy. Well, if you have any questions, so please feel free and to ask me anything that may concern you.